Good morning, good afternoon to people in different time zones. And I'm Tom Gloper. I'm from Nashville, Tennessee. It's my pleasure to host this Q&A session. We've got two fellows that we're going to have a nice discussion with. We got Dr. Matthias Girndt from Martin Luther University in Halle, Germany. Dr. Alp Ikizler is from Vanderbilt University in Nashville, my colleague, actually my boss right now, and we're open to questions about the discussion that we've had this morning. And let me just see, at the moment we only have 6 participants, so that's up to 7. Anyway, good morning, good afternoon to those. Gentlemen, let's continue that discussion. The discussion was about improper inflammatory response, be it deficient or overactive and other circumstances of patients with kidney disease. And Dr. Girndt has discussed that. He's discussed some of the mechanisms and his concerns about it. Dr. Ikizler is a specialist in inflammation and nutrition and their relationship. And we had been talking earlier about muscles, skin cells, and their role in inflammation and perhaps the predisposition to dying of inflammation or, for that matter, infectious diseases. Did I summarize, Dr. Girndt and Dr. Ikizler, either of you, did I summarize our discussions?
You did a wonderful job, Tom, and thanks for the questions. I think just to continue the discussion, and we were discussing how this inflammatory response and the metabolic abnormalities that are associated with this inflammatory response sort of starts earlier than anticipated, and then it becomes a multifactorial process where the dialysis adds on another layer on top of it. But there's an initial activation of the inflammatory cascade and associated other metabolic problems. We know that it's just inflammation is one of those terms that we use as an umbrella for any kind of abnormality we see. And anything we do not know about and anything we cannot fix, we sort of blame inflammation nowadays. And I think that's not for nephrology alone. Happens in rheumatology, because I got this from a rheumatology colleague. He said, well, if you say it's inflammatory, that means you don't know why it's happening. And that's why you blame the inflammatory cascade for this whole process. But clearly, the kidney disease itself initiates or is associated with things. And one of the things that we've discussed, as you pointed out, is this volume status and heart failure and how extra fluid or electrolytes stored in the body actually stimulates this process.
So we have a question in the Q&A, but before I get to it, I want to ask Dr. Matthias, you had earlier you had talked about bacterial products translocating and then inducing an inflammatory reaction. Could you expand on that just a little bit? Because it goes to the question in the Q&A, which I'll come back to.
Yeah, that's a very interesting topic and a very interesting question. Thank you. I'm convinced that there is some translocation of bacterial products and endotoxin in patients that are highly overwhelmed with fluid. You know that from dialysis patients, but you also know that from patients with chronic heart failure that have too much volume in their body. This leads to a translocation of bacterial products and can lead to inflammation. And there's one other aspect. There are some uremic toxins that are formed in the gut. For instance, paracrosyl sulfate is produced in the gut by the gut bacteria, and potentially this substance can translocate into the circulation much better in patient who is overhydrated. I think this is one aspect that we should look at and put our patients in euvolemia to reduce the translocation of these substances into the blood. This is one aspect to attack inflammation.
So that leads to one of the questions in the Q&A, which says, which asks, is there an anti-inflammatory diet? Is there something about nutrition that could become anti-inflammatory? And I'd like for both of you to answer or respond to that. Let's Alp first, and then Matthias.
So this is a very common question. You know, are there certain things we can eat that can help our anti-inflammatory state in general? Studies have shown that in general, using diet as a therapy is not as specific as we want it to be. You know, I will tell you up front at the get-go, outset, that I can't tell you one food group, a particular nutrient that will make things anti-inflammatory in the body. The diet is a complex process, and it includes a number of different micro and macronutrients. So we never eat selectively. We eat a diet that has different components to it. And the way to have an anti-inflammatory diet is to be able to get nutrients that are less inflammatory rather than anti-inflammatory into your diet. For example, if you think about it, fat ingestion will induce a sort of insulin sensitizing effect that leads to inflammation in itself. So you need to be limiting your fat in your diet to some extent, but you cannot completely cut it out. And then there's no different diet that will come in and say, okay, that's going to be taking away all the inflammatory things, so I can eat whatever I want, and then if I take this specific nutrient, everything will be fine. So in general, what I usually say is that not to eat too much of anything, have a very balanced diet, and try to use things that have shown to be more healthy in general, like the fruits and vegetables and other things. Now that becomes always an issue for patients with end-stage kidney disease, especially one on dialysis. So it's not an easy task to be able to say, eat all the fruits you want, eat all the vegetables you want. Try to be relaxed on this, because there's these additional electrolytes and components of those nutrients that could be deleterious to the patients. But for the ones that are in the earlier stages of kidney disease, all the way to stage 4 and 5, I think a diet that includes more vegetables, fruits, fiber is more likely to be anti-inflammatory in general, not specifically in general. And a healthy individual as well as a patient with reasonable residual renal function should be following that. I hope that helps.
Well, it helps, except I didn't want you to make that comment about butter that we had discussed earlier, and you did.
Yes, butter is not, certain types of fat is more inflammatory than others. But again, you cannot completely exclude those out of your diet, because diet is not designed to be very selective. Otherwise, you will lose this satisfaction out of eating. So you cannot force people to eat things that they don't like, they cannot tolerate. So as a dietitian or as a physician that helps with diet, you have to really understand that, being careful about the amounts and balancing it out is the key issue. I'll give you another example, like fish oil, or the foods that include certain aspects of EPA or DHA are thought to be anti-inflammatory. But in general, studies have shown that even if you give these as tablets or capsules in additional amounts, it does not help to the patient's inflammatory state as much as we hope to. Maybe it's helping to some extent, but it's not like the silver bullet.
Matthias, your comments on the same subject?
Yeah, thank you, Alp, for this wonderful response, and I totally agree. And I would like to point out that the substances that I'm thinking about as inducers of inflammation are mainly bacterial products. This is true for endotoxin, and this is true for paracresylsulfate and other uremic toxins. And you know how difficult it is to change the microbiota of the gut by changing nutrition. There are approaches that try to do that, but I'm not really convinced that we can do this in a way that helps against inflammation. So there definitely is not anti-inflammatory diet that has shown this effect convincingly.
So thank you both. Another question that's come up is about lifestyle, and I'm going to expand on that. So the question was lifestyle and sleep, but I'm going to go beyond that to happiness. Okay, are happier people less inflamed? Are people who find joy responding to inflammation better? The question was about sleep, so you can address this in whatever way you feel. And it goes to the previous discussion, and I'm serious about this because I've helped make croissants, and I can tell you how much butter is in them. And there's no one that doesn't like a croissant. And it goes to that concept of pleasure and the role of lifestyle and happiness and translate that into inflammation and your response to inflammation. So, Matthias, would you like to go first on that subject?
Yeah, that's a difficult question, and I would very much like to believe that happiness is anti-inflammatory. Maybe it's the other way around. There is a connection between inflammation and cognitive dysfunction as well as depression, at least in patients with chronic renal failure. So maybe it's something we could not that easily modify by doing things that make us happy or by eating butter. But I'm not sure about that. Well, there is a relation between inflammation and depression in these patients. That's clear. And maybe there's also a relation between sleep quality. This is a hypothesis that interests us here very much. We are going to study sleep quality in dialysis patients in relation to inflammatory markers right now in a new project. And I think that is a very good idea to study that.
Alp, your comments on that?
So let me tell you a couple of things. I think one of the questions is a follow-up to the previous discussion is the gut microbiota and how certain diets could be anti-inflammatory. And then there's one question that says that vegetarian diets actually lowers the uremic toxins. I have to say, everything happens relatively. If you really take a cohort of individuals who are vegetarians, like in certain countries, in India, for example, there's a group of individuals, a substantial number of people who are vegetarians. If that idea holds true, then none of them should have any inflammation. And that's not the case. There's no data to suggest that vegetarians actually don't have that generalized inflammation. So what I'm trying to get here is that, yes, it might help to some extent, but balancing the diet to a certain point is more important than just completely switching one diet to the other. And that also links to what you said. Being happy is less inflammatory. Not eating what you want is a depressing problem. And if you're depressed, you're more inflamed. So the most important that I tell people is that you cannot force food to people. Food is not a medicine type of an approach. The way when we eat, we really enjoy and be happy. And your point about croissants is clear. Yes, eating a bite or two of croissant a day is okay. And it's not going to kill you, for sure. It's not going to increase your inflammation, for sure. Now, if you eat croissants breakfast, lunch, and dinner for a long period of time, that will probably cause a problem. But again, I hear what you want to do is, because depression is associated with inflammation, it's a two-way street. Inflammation causes depression. Depressed people seem to be more inflamed. You really need to make sure that you don't really push people to a stress level about their food. So you need to give them options in terms of what they can eat so they can feel good about it and less depressed and be happy, and subsequently probably less inflamed, if that helps.
Okay, thank you. The questions are coming in, hard science questions. So one of our colleagues at RRI has asked you, Dr. Girndt, about ACE and ACE2 imbalance. and asking, is there a potential therapeutic target there? What are your thoughts about giving soluble ACE2 to dialysis patients if they seem to have a pro-inflammatory phenotype?
Yeah, that's one topic of my talk, showing that there's a disbalance between ACE1 and ACE2 molecules on the cells, and that this is related to the monocyte dysfunction. And definitely it's an interesting idea to inhibit ACE1 and to upregulate or supplement ACE2. However, since we found that there is a specific microRNA that inhibits the expression of ACE2, our primary idea is to inhibit this microRNA, and this should be possible in the future in order to upregulate ACE2 again. I'm not aware of a clinically available stimulator for ACE2 right now. And so maybe it's easier to go the way via the mRNA.
So is there any way now to address this system? So just renin-angiotensin system blockade, is that of any general benefit since we don't have the tools quite ready that you're mentioning?
Well, the data suggests to use ACE inhibitors in these patients to improve monocyte function. However, the problem is the balance between ACE1 and ACE2 with downregulated ACE2. We know now that ACE inhibitors, as we use them for blood pressure therapy, influence the system and can, to a small degree, also upregulate ACE2. But this doesn't seem to be sufficient in the presence of this high levels of microRNA 421. So we need further pharmacological tools to address the system. It's simply not sufficient to inhibit ACE by standard medication.
Another question from one of our RRI colleagues has to do with the immune system and kidney crosstalk. You've alluded to that a little bit, but I think if I understand Laura's question, it might be what is the immune system doing to the kidney to either improve or exacerbate function above and beyond fibrosis and inflammation? Is there any other formal crosstalk? We had talked earlier about the immune system involved in sodium, and the kidney is the major organ of sodium excretion. So if I can expand on her question to either of you. Alp, you want to start with that? Do you have any comments?
Well, I'm going to let Dr. Girndt talk about that because that's his discussion point.
Okay.
In his talk, and then maybe I can add some more based on what he has to say.
Matthias, it's back to you.
Yeah, I'm not sure if this question addresses the inhibition of progression of chronic kidney failure, or if it addresses the role of kidney failure in immune dysfunction in patients that are not on dialysis, that have early stages of kidney disease. To address the last item first is we know now that immune dysfunction starts as early as CKD3. It's not only a problem of dialysis patients. When the patient gets on hemodialysis, there is an additional impact by the pro-inflammatory effects of the membrane contact, but this adds to a defect that starts much earlier. And there is data showing that it starts with CKD3. So these patients already have decreased vaccination results. They are already at a higher risk of infection-associated mortality, and they are most likely also at a higher risk to have severe COVID disease, for instance. That is the one thing. The other is whether these alterations of immune function also add to the progression of chronic kidney disease. This is very possible, but I'm not sure whether it's the same mechanism that is relevant here. This needs to stay open. I don't know the answer for that.
So, Alp, if I can interrupt, because I know you were going to respond, that you've tweaked me to ask you a follow-up question, Matthias. So you have, there are models of CKD in humans who have some disease that's predominantly a renal disease or a metabolic disease like diabetes. But let's look at loss of renal mass that is purely surgical, okay? So trauma to a kidney, laceration to a kidney, you were on the losing side of a knife fight, you know, and now you've reduced renal mass, or cancers. So you now are reducing renal mass. Do you think you would see some of these same phenomena, because then it's an issue of loss of renal mass versus some underlying disease process that's affecting the kidney?
That's a very good question, and maybe we look at patients who donated their kidney for living transplantation. And as far as I can see, there are few studies on inflammation in these patients. We know that the healthy person that gives a kidney to another stays healthy and does usually not get progressive chronic kidney disease. So this is an interesting topic to study, whether there are early signs of chronic inflammation in kidney donors. I'm not aware of studies that have addressed this topic.
Can I add to that, Tom, one thing? And this is more of a clinical vignette than anything else. But, you know, the patients that we follow with the sort of loss of mass are the ones with renal cell carcinomas, where they have one kidney taken out and then they have another kidney with partial nephrectomy. And interestingly enough, my own experience, and I would only say for my own anecdotal experience, that these patients seem to be rock steady unless they have a second hit or a third hit. If you add diabetes to these people, it doesn't go well. If you add, you know, high blood pressure to these people for an underlying disease, when they come to you before the kidneys are taken out, that's a problem. But if you get a 45-year-old, 50-year-old with newly diagnosed renal cell carcinoma with 1+ the second kidney is partially taken out, they are rock steady for a long period of time. So that indicates that you know, the kidneys are pretty resilient to trauma. What the kidneys are not resilient to is metabolic abnormalities. I think the kidney cannot handle inappropriate metabolism of nutrients and metabolism within the kidney. The kidney itself is a hypermetabolic organ. So there's a lot of, you know, circulation or anabolism and catabolism of nutrients. And if you cannot do it appropriately, there are a lot of intermediate products that end up accumulating in the kidney. And data from Kathleen Sistek and others have suggested that intermediate products, like acylcarnitines and other things, especially for the fate of the fat lipids, can actually induce fibrosis and interstitial nephritis. And that happens more in patients who have additional diseases that predispose to metabolic abnormality, most importantly, diabetes in the background. So that is the one that you need to be careful about. How immune response and kidney crosstalk happens and how that really affects the kidney is a little bit of a hard question, because now you're really thinking about both the way that the body is going to respond in the setting of uremia or accumulated uremic toxins. And data have shown, and Dr. Girndt knows that and shown that and everything else, that uremic toxins per se, if you take them out and expose to the cells, the ability of macrophages to respond are less in the setting of having uremic toxins. Then it all becomes of how much uremic toxin you have. And interestingly enough, when you look at patients with stage 3, 4, 5 kidney disease without dialysis, the levels of these uremic toxins are not consistent in everyone. And there comes an issue of what really leads to this different levels of precresol or others, inductyl sulfate and others, you versus I. Why is it that way? Is it something we eat? Or is it the way we have genetic predisposition? Is it our gut? That needs to be clarified. And those people with the higher levels tend to have a worse immune response.
And some of those toxins are protein bound. And what is the status of your protein binding sites? Because at least if they're protein bound, they're not working on those cells. So we're going to change gears. Dr. Katanko is asking about hypoxemia, and it's in the setting of sleep apnea at night, so hypoxemic then, as well as volume overload, so hypoxemic from fluid in your lung. And he's asking for the potential role of that. He's mentioned a paper by Myring and Western in 2016 about the pro-inflammatory effects of hypoxemia. I'm going to throw that out, Matthias. You want to get first shot at that?
Yeah, hypoxemia is one potential factor that induces inflammation as well. But it's very hard to separate that from the stimulation of, for instance, catecholamines or steroid hormones that also occur in the situation of hypoxemia. So we don't have these data showing that it's exactly hypoxemia that induces monocyte activation, for instance. You cannot show that in vitro in experiments that separate the system from all these hormonal responses of the body. So I'm not sure that hypoxemia is the actual inducer of inflammation. I'm more thinking that it is other factors in the body responding to hypoxemia that do this.
We have only a few minutes left, and I want to throw something at both of you. And Alp knows a little bit more about this because I've taken some advice from him. But so I'd like to make a differentiation between dialysis patients, and I'm going to make them into three categories. So hemodialysis is going to be broken into two categories: those with a AV fistula versus those with a central venous catheter, and I'll compare them to peritoneal dialysis patients. And the role of I think those three groups are different inflammatory-wise. I'd like to hear your opinions from both of you. Let's start with you, Matthias, first.
Well, we know that patients with central venous catheters are more prone to inflammation, and those are the patients at the highest risk, and much more than patients with peritoneal dialysis. People sometimes used to think about peritoneal as the inflammatory and infectious risk dialysis. I don't think this is true. It's the central venous catheter and the bacterial growth in biofilm in these catheters that puts the patient at the highest risk.
All right. That's so true. some variation of contamination of the catheter in the vascular system. Yeah. Alp, comments?
Yeah. So I'm sorry to disappoint you, Tom, but interestingly enough, peritoneal dialysis patients tend to have same level of systemic inflammatory state as hemodialysis patients. So this is, we assume that PD patients don't have that, but they do, and that goes back to Dr. Girndt's comment about it's about the loss of kidney function that leads to inflammation rather than the dialytic procedure. PD, through some other mechanism, may or may not increase that inflammatory response. Hemodialysis definitely does it on frequent basis. Sometimes you can think that the dialysis increases inflammation because it does to some extent, but it comes down. And then the catheter issue is based on our studies, early studies. We looked at this in a large cohort. It's been a long time, but new fresh catheters are more inflammatory than the ones that have been there for more than 2 or 3 months because it's just a new exposure to the body. And then over time, the body sort of adapts to this, a non-body, non-self thing and doesn't really produce more inflammation unless, as pointed out, if there's a biofilm that sits there and that becomes infected. And that's when you really get stressed out. I would say catheter is never good. You all know that. There's no question about it, and nobody's going to argue about it. And PD is probably, and I would say this conclusively, that it's more physiological. You all know that as well. But they all have their own problems attached to it. So you really need to be very specific and personalized to the patient and say, what is the primary problem for inflammation? And then for me, poor nutritional state, and fix that problem rather than say, this is applicable to everyone. Got to be a little bit more precision medicine, precision nutrition, precision dialysis in our management, and take each and every patient and treat accordingly.
Matthias, any closing comments?
Well, I couldn't agree more, and this is perfectly true. And the new catheter into the veins is a foreign body that will be covered by albumin and other proteins over the time, and this improves biocompatibility unless there are bacteria in them. That's perfectly true.
Well, gentlemen, thank you. I enjoyed it. I hope you did. I hope our participants did. We have 36 people on board. And
thank you for everyone's time. And thanks for an outstanding moderator.
Thank you very much. It was a pleasure.
All right. Thank you both. All right. Take care.